All right, just an update. We'll be starting here in a minute or so. Randall has notified me that he's working his way on, so we'll be starting here pretty soon. Um, while we wait, why don't we actually get through the first part of our agenda here today, which is just introductions. So, hello everyone. My name is Neftali Serrano. I'm the executive director of the Collaborative Family Healthcare Association, and I thank you for your membership. Your membership's really, really important for moving integrated care forward in this country. And I also want to thank you for your participation in the Families and Health Special Interest Group. This is a real core value of CFHA, and the topic today is reflective of a core value of ours, that healthcare in the United States be more family-oriented, family-centered. And there's going to be some real practical discussion today about how to influence the healthcare professionals that provide this care. And so I'm interested to hear how this conversation develops today. Our presenters today are pretty well known to you all. They are Matt Martin and Randall Reitz. And Matt, you know probably from a whole lot of different areas. And sorry, that's actually Randall texting me that he's having trouble getting on. So Liana, if you can just email Randall the link, see if we can get that going.
Sounds good.
So Matt Martin, you know from his many roles at CFHA, he is our head lead blogger. So if you go to our news site, integratedcarenews.com, you will see blogs that are the blog team, which is led by Matt and edited by him. He does a fantastic job with that. But beyond that, he provides a wealth of leadership. You've seen him post his work related to echo groups. And of course, his work with the Families and Health Special Interest Group as well. So Matt's kind of all over the place. And then Randall, who has just joined us as well, you also obviously know, he almost needs no introduction. Really a longtime CFHAer. He has served in various roles, including my role years ago as executive director. He has obviously been very active and led the Families and Health Group, and he's also a former board member. So these are folks who come with a wealth of experience on the topic and some great perspective on family-oriented care and professionals. So the only other business item is just reminding folks about our conference this year. We already have really pretty high-paced sign-up for the conference. As of this morning, we had 290 people signed up for the conference, which puts us on pace to break our record-breaking pace of last year. And I say that not just to promote the conference, but also to encourage those of you who are going to the conference to make sure you reserve those hotel rooms. We want to make sure that folks are able to stay at the hotel as much as possible and not have to go to external hotels because it gets filled up. So make sure to get your hotel rooms as quickly as possible. All of that information you can find on integratedcareconference.com. All right. Without further ado, then, I'll turn it over to Max Zabotsky, who's going to help us help frame the discussion for today.
Thanks, Neftali. Hopefully you can hear me okay. I know there's probably a little bit of reverberation. I'm at the APA conference, so I'm trying to roam around the convention center here. But yeah, my name is Max Zabotsky. I'm a professor and program director at St. Louis University in the Medical Family Therapy program. I'm the chair of the Families and Health SIG for CFHA. Just a quick plug real quick, for those of you on the call who aren't members of the SIG, feel free to join. We have some neat stuff that's going on, including a quarterly blog that we're giving contributions, which myself, Randall, Matt, and Stephanie, who's also on the call, have contributed to, as well as some really neat webinars around family systems topics, family-centered themes, and so forth. So today's topic on training future professionals on family-centered care kind of derived out of a few things. Many of you may have read the article in Family Systems and Health a few years ago from Larry Mauch and Colleen Fogarty, Imagine a World Without Family Systems Thinking. That got many of us in the field really talking about not just our vision about training professionals in healthcare, but really what are we missing as well too? Are we needing to develop more evidence-based practices and skills around families? Where's the research around family-centered care and outcomes? Are we doing as much on the advocacy and policy side of things? We also have a pre-conference this year on Thursday on this topic. So this is a really good primer, kind of also CFHA advertisement. Stay tuned for the pre-cons that includes this topic as one of them, which we'll talk about. So we wanted to have Matt and Randall. Unfortunately, Gina Lee could not be on the call today. She was unfortunately ill, but she can send over some stuff later on, some good information from her end. But I thought we could format this as Matt and Randall could just give a few mini talks from their end on how they train and how they see workforce development in family-centered care and practice. And then I'll do a little bit of Q&A with them, ask them some questions, but then we really want to make this conversational too. So people on the call, if you have ideas, questions, things that have worked, other challenges, we want to make the last 15, 20 minutes interactive. So with that introduction, we figured the first, well, we can extend this 5 or 10 minutes for Matt and Randall each. They'll give kind of their spin on their training, mentoring, and ideas as well too. So maybe if we want to start out with Matt, I don't know I know you may have had some slides or wanted to share your portion of the talk first.
Sure, that's fine with me. I've got some slides. I had a question, Max and Neftali, do you want me to turn on my camera or are we keeping cameras off?
Camera on is fine if you like.
Okay, just so you know it's me.
Yeah.
Okay. Yeah.
Okay, hopefully you all can see me. I'm gonna share my slides. Okay, you all can see that? Oh,
Looks
no.
good.
We can. Yeah, perfect.
Okay, great. So Max asked me to talk first about my experience in training professionals in family-oriented care, and then also talk about who has influenced me, and then I can jump into the slides at that point, just to share some of my thoughts about workforce development in this area. So for me, I was training professionals about 2 years ago. I was a behavioral scientist at a family medicine residency program in North Carolina, and I was training family medicine residents as well as medical students in how to work with families, how to engage them in care. And then I also had some behavioral health interns that were working with me as well, social workers, marriage and family therapists, and I would also teach them about how to engage families as well. So since then, I've moved on to ASU, and I'm getting more involved in research, and so I'm not actively training at this point. But it's actually given me an opportunity to take a step back and to think about workforce development just broadly when it comes to families and health. And so I can talk more about some of my ideas. As far as mentorship, I had the opportunity to complete a fellowship with John Rowland. He's a psychiatrist who lives in Chicago, and he runs the Chicago Center for Family Health, They're, along with his wife from a Walsh, they are a power couple in the world of families and health. They've written a lot of books on this topic, but he has been he's made a great impact on the way that I think about this area and the way that I frame some of my questions as well. So the things that he taught me are first that there are a lot of things to consider when working with families: the type of illness or disability that they're dealing with, the type of beliefs that the family has, what has happened in the past for the family, their multi-generational legacy, as well as what stage the family is in. So a lot of things to consider when finding the right treatment or intervention for a family. And then second, one thing that he taught me is about how important it is to consider the instrumental needs of a family. For most of my training up until that point, before my fellowship, I was really focused on the emotional and psychological needs of my patients and their families. But then John was, very gently encouraged me to really focus on the day-to-day, daily activities and needs that families come up against. So things like going to multiple medical appointments, or providing caregiving, from day to day. Those kinds of things that sometimes are more important than the emotional and psychological needs. And so he introduced me to like a hierarchy. If you think of Maslow's hierarchy of needs, he introduced me to a hierarchy of family needs when it comes to illness and disability, and that made a big impact on me. One other thing that he taught me, and this is the segue that I'll make into my slides, is that he taught me to think about families and health, at least from a training standpoint, broadly. To not just think about MFTs like myself or other specialists in mental health, but to think about the entire team: nurses, allied health, medical providers, medical assistants, even the front desk staff, to think about the role that they all play in engaging families. And so I'll talk more about that as I go through these slides. So like I just mentioned, I think it's important when we think about workforce development with family-centered care or family-oriented care. And I would say that there is a difference between family-centered care and family-oriented care. And I can talk more about that in a minute. But I think we need to include the entire team. Healthcare is moving toward more integrated, team-based care. That's probably going to become more of the norm than the exception in the future. And so each team member has to have some kind of training, some kind of orientation to what it means to engage families, to help them problem solve, to help coordinate care and connect them with the right specialists if that's what they need. And so that can include people like you see right here, as well as paraprofessionals, community health workers. So for me, I do see two levels of care. I see the specialists, and then I see the non-specialists. So a specialist would be someone like a medical family therapist. And I think we've done a lot of great work up to this point in defining what the specialist does. Medical family therapy has come a long way. There's some great training available, a lot of books and articles written about what specialists can do to work with patients and their family caregivers. I think that one area that needs a little bit more attention to take us even farther is to focus on the non-specialists. So these are all the other members of the care team. When it comes to how we engage these families, it may be helpful to think about three levels of targeting, or three ways that we engage families. And this is the kind of training that we can provide to the rest of the care team. So one level, which might be considered a lower level, or at least a less powered level, would be just reactive support and intervention. So a family member may come in, or a patient may come in, and based on what their presenting problem is, the care team can react to that and provide support and intervention. A step higher than that would be universal screening, and this is where the clinic is giving everyone a questionnaire or asking broad questions about some of their family needs. And then the highest level of targeting would be targeted treatment, and that's where the clinic is using their health record data, including claims data, maybe even non-clinical data, to identify those families that may be at the greatest risk of needing some kind of support or intervention. The targeted treatment can be considered ideal, and I would say a lot of clinics and hospitals are probably not working at that level yet. But that's hopefully where we will head to make care a lot more preventive and family-centered. So let me talk just a little bit more about competencies and the way that we train professionals. So like I mentioned, some great work has been done in the area of medical family therapy. AAMFT recently put out some competencies a couple of years ago, and they provide a great list of some of the skills and knowledge that specialists should develop if they want to be effective in this area. When we think of other mental health disciplines, I'm not aware of a lot of other publications or competencies about how those other disciplines work with families. I think a lot of programs have maybe a course in family therapy, or maybe they refer their students to read more about medical family therapy. But it seems that most of the conceptual development, most of the work in terms of figuring out what these competencies are have mainly happened in the MFT realm. When we look at non-specialists, there's been a lot of work done in nursing. In fact, I would say that they are probably way ahead of a lot of other disciplines in terms of the way that they train their nurses, and also in the kind of targets that they have for their students. You can look at people like Lorraine Wright and some of the work that she's done, as well as Janice Bell and Wendy Nelson. They've done a lot of work in the area of family nursing. For medical providers, physicians, PAs, nurse practitioners, you can look at a lot of the work that Susan McDaniel has done, as well as Dan Felix, another MFT, has started working in this area as well, and he has something called the Family-Centered Observation Form. If you just Google that with his name, you can find it, and that also provides more guidelines and principles for how to train non-specialists. And then looking at allied health, so people like physical therapists, occupational therapists, I just have not been able to find much about how to train those professionals to work with families. So I think there's still a lot of work to be done. So when I think about non-specialist providers, these are some of the skills and knowledge that I think they need to effectively work with families. So they definitely need a systems viewpoint. They need to have that broader view of how family systems and health problems interact with each other and have a bidirectional relationship. They should also be aware of some of the common health-related family problems that come up, whether it's because of a chronic disease or terminal illness. They should have some ability to predict what kind of problem a family is likely to have based on the illness that they're dealing with. They should be able to identify these problems and have some basic skills to counsel or at least to engage and support the families if that's their role. So when we look at specialists, there are degree programs out there, certificate programs. You can go to workshops at different conferences. There does seem to be a lot of really good training available for specialists at least in mental health disciplines. But not so much for the non-specialists. There might be some classes. They might be able to participate in some of the certificate programs, but I haven't seen a lot of degree programs or residency training, at least outside of family medicine. And that's okay, because when it comes to some of the non-specialists, they probably don't have to go to a degree program, or it may not have to be part of their residency. For some of them, it may be part of their CE or their on-the-job training. So in my experience working in workforce development, I've learned that didactics, of course, play a role, but also observation and feedback sessions. So once you're very clear about what the target is, what kind of skills they need to develop, and you've given that to them through didactics or a skill-based workshop, it's really important to be able to observe those professionals and give them feedback on how they're doing. And there are some places where that's just not possible. There may not be a supervisor or an expert at the clinic who can observe them and give them feedback. Those are just the limitations. But ideally, for someone to really develop competency, they should have an expert who is observing them and giving them feedback on how they can get better. Okay, so this is the last slide. In terms of next steps, I think there needs to be some work done about how family or oriented care is done as a team. There's been a lot of work done about what one person does, but we don't really know a lot about how the team works together in coordinating care, in sharing the responsibilities. Of course, not everyone on the team needs to provide counseling or needs to provide family therapy, but there should be a sense of how the whole team works together to identify the family, provide them support, and maybe even connect them with the right specialists. Just an entire workflow. That kind of protocol, I just have not seen very much. I think it's a rare thing these days, which is unfortunate because a lot of people talk about patient and family-centered care, and I think healthcare has become more patient-centered, but I think the term family-centered care, at least at best, is still vague and not very well defined, and maybe at worst is just lip service. I think people may just kind of throw that in with patient-centered care, but not really have any clear sense of what it means or what it looks like. I think another step that we need is to develop technology that makes family care a lot easier. So whether that's developing templates for what kind of data we record about the family, maybe it's a family genogram, that would be awesome. Or maybe it's just having on record who the family caregiver is and their contact information, and some data about how they're doing, what's their stress level, what's their support. I think we also need some new payment models, maybe even some new codes that incentivize clinics to make their care more family-centered. It's amazing what happens when you start to open up new codes. Clinics start to develop new protocol so they can maximize those codes. So I think that's a very important step. And last, I think that some of the regulating bodies in higher education need to seriously consider making family-centered care standard, making it a requirement for training institutions to receive accreditation. I think if we're going to be really serious about engaging families and helping them to be successful in taking care of the patient and having better outcomes and reducing costs, I think we need to make family-oriented care a requirement for training. I'm not sure what that would look like. That'll probably look differently for each discipline, but I think that's a step that needs to be considered. So I'll stop there. And
okay,
turn the time over.
Thanks, Matt. Appreciate it. We'll probably do a little bit of Q&A after both talks, because I know we want to give some time for audience input as well after both. So, but that was great. I got a lot of questions and things as well. Should we transition over to Randall? No, well, the same time frame. We'll have about 10 or 12 minutes, a little longer, because I know Gina couldn't make the call. But if Randall's on and wants to share his talk. Okay. I don't know if I can hear you, Randall. I don't know if your mic is on.
Is that better?
There we go.
I was on mute. Sorry about that.
That's okay. So yeah, but about 10 to 12 minutes, same time frame as Matt. We'll have a little bit longer. So.
All right. Can you see my screen?
We can.
Okay, good. So I'll follow Matt's lead. I was very fortunate to be mentored in family-oriented care by some of the best people in the field. I remember one of my first weeks in my master's degree program, I had a supervisor named Lawrence Passmore, and this was, back in '96, I think. And he said, "Randall, I want you to fill out this form with your patient. It's called a Psychosocial Assessment." And I was like, "What is that?" I hadn't even heard of that term, biopsychosocial, and I had come into the field with a very narrow view of what family therapy would be like, and it didn't involve biology for sure, and had a pretty skeptical view of psychology also. And to have my faculty saying, "Hey, this is how we're going to start things here." I think the patient was reported to have diabetes, and this was in our little university clinic. And so I didn't do any sort of collaboration at all with the person's medical team, but just that first little nudge toward it got me thinking, because I have a brother who has diabetes and a cousin with diabetes, and I was just always shocked by the difference in how diabetes was managed in the two households. I had the great fortune of coming from a very stable family household, to where we had a structure, two parents in the home. We had breakfast and dinner together every day, pretty much. My dad and mom made a good living income, and so we were comfortable. And my brother did just fine. He was always kind of self-conscious about diabetes. You would never see him checking his blood sugars or injecting insulin in public, but he managed it very well. And then my cousin came from a family that had addiction and very struggles with day-to-day incomes, kind of living paycheck to paycheck, lots of payday loans, and diabetes became the focus of their whole family. And there was constantly bickering about diabetes and, "Did you check your blood sugars today or not?" And it took her about 25 years to figure things out. And she went through her own bouts with with addiction, and is now a great advocate for addiction services. And she seems to have created her own family where things are going much better. And so that's always kind of a touchstone for me, a reference point about, what is the connection between the biomedical and the psychosocial, and then with the psychosocial having at the heart of it the family. And so he kind of got me started. And then I, for my dissertation, my PhD, I was a student of Wendy Watson. Matt Martin mentioned before the Calgary Nursing Group, and she was one of the founding mothers of CFHA and also of the collaborative care movement. And she was just a great, she just was such a master clinician. I had several practica with her, and just to watch her engaging the whole family, especially couples. She was a masterful couples clinician, and how she brought in the medical and the psychosocial and the family all together. And then once I went on for my internship, I was with Larry Mauch, and he is obviously a great family therapist and who did a great job of training me up and how do you especially train for family-oriented care. And so I'm going to focus a little more narrowly than Matt did on creating a culture of family-oriented training in a family medicine residency. That's where I have done all my training. In our program here, we have 27 residents, and then we have several different levels of behavioral trainees. We have doctoral fellows and postmasters, interns who are family therapists, and then we have social workers at the master's degree student level, and then the undergrad level. And then we also train exercise physiology students from the local university. They come out and do exercise groups with our patients. And so talking about within this residency setting, where you have interdisciplinary training going on, how do you create a culture of family orientation? And I'm going to just share 5 things I've come to believe about that. Let's see if I can get this to work. Okay. So my first idea is mentoring physician champions. I think this is the core. I'm sorry, maybe we'll go back one. Okay. For me, this is the core that the biggest mistake I can make in training physicians is giving any sort of idea that family-oriented training and family-oriented care is in the wheelhouse of family therapists or psychologists or social workers. That, and especially in family medicine, there's this ethic of cradle to grave services that involve the whole family, that where the family is the unit of care. And we have signs up in our clinic that talk about these 10 principles of family medicine. And I think the third one is the family is a unit of care. And that was been up there since before I got here. And so to work in a place where that is the kind of the perspective is very important. Somehow my slides are advancing by themselves. I'm sorry. And so for me, that means mentoring them is kind of nurturing that in them. And so for me, I have been very active inviting my colleagues to come out to CFHA several times and presenting with me on family-oriented care. Because I find that things that we present together become parts of what we believe much more deeply. And so that's been very successful. Whenever I have a presentation on family-oriented care, I'm always going to make sure that I'm co-presenting with a physician. And so just kind of giving themselves a sense of, I'm a family physician, I do family-oriented care, I think is the essential first ingredient. The next thing I would say is to codify family-oriented care expectations. We went through this process a couple of years ago where we had a residency is kind of a unique setting where you have 2 different functions. You have a clinic that sees patients, and you have a residency that trains doctors and behavioral health staff. And typically they interface because the clinical staff for the residency clinic are the physicians, the residents and faculty of the residency. And so that's where they intersect. But we had this thing where we were creating different mission statements. We had a mission statement for the residency and one for the clinic. And it was kind of emblematic of these problems we were having, where we had competing missions, competing perspectives, competing budgets, competing priorities. And so we were challenged by consultants to say, why do you have 2 different mission statements? Why don't you just have one mission statement that will encapsulate where you're most aligned? And so we did that. And in that process, we had the word patient-centered care in the clinic's mission statement. And we said that shouldn't be patient-centered care, it should be family-centered care. And so that's kind of the first step we did to codify the fact that we are focused on family-centered care. And we have this mission statement is up all around the clinic and in the residency building. And so it kind of becomes a point of focus of what are we doing to create family-centered care. And so if you have physician mentors and you have this kind of codified thing saying this is how we do it, you're on your way. And the next level for me is creating competencies and milestones that are specific to that. In the family medicine credentialing, through ACGME, there's a lot of language about family-oriented care, and it always says patients and families, patients and families, patients and families. But they don't really have milestones as much that are as explicit about that. And so we went through and rewrote all the ACG milestones to have that family-centered focus. And we kind of expanded some so it was more specific about what does good family-centered care look like. And then we have, we created milestones checklists for observing care that include questions about family-centered care. And so we have physicians, again, who are champions, who are watching our residents train, who are giving them feedback on the quality of their family-centered care. And then for us, in the second year of residency, it's a 3-year residency, they have about 10 days with our behavioral team. And that's a requirement for all second years. And that's, and a big component of that is, going to be behavior modification, assessment, but also a large part of it is family-oriented care. And so, again, that's going to be, 3 residents meeting with our behavioral faculty and one of our physician faculty, all talking about family-oriented care. What does that mean to us? How do we do that? What does it look like when it goes well? What's the examples of poor family-oriented care? And so that's part of the required curriculum. But then the next one is to integrate it across the curriculum, such that even though I don't have much to say about the PEDS curriculum, we are pretty influential with them in saying, how can we have the PEDS curriculum be family-oriented? Or we have our teaching service, which is where residents spend time in the hospital learning to do inpatient care. How can we have inpatient curriculum be family-focused? And how can we have those milestones documents be family-focused? How do we train residents to do family case conferences and then carving out time within their busy rounding schedule to have care conferences with families where they're meeting alongside our behaviorist staff to support them and help them to feel more confident. But that in that setting specifically, there's obviously lots of need for family caregivers to be supporting and to help people make some difficult decisions. And so making sure that residents are trained in that setting to involve the whole family as much as possible and to make it the standard of care that when you're making key decisions, that it's not just the patient, him or herself, but it's involving their family, it's involving their trusted loved ones, it's involving their social support. And so those are the 5 ways which I found to be most helpful in training family physicians to be to bring on a family orientation.
Outstanding. Thanks, Randall. That was great. I really like how you and Matt had some different viewpoints still on the same topic, one more of a residency curriculum, another on the professional skill development of people in the field. I just had a few questions for both of you, and then I thought since it's a small group, we could turn the time over to the larger audience. I was curious, both of you brought up competencies in your slides and benchmarks that we need to have. Do you think we're doing a good job, whether in residency training, graduate education, as far as making competencies intentional, that's an incentive enough for mentors and future trainers to do this? Or do you think there's challenges that's been done around that? Because I know both of you talked about that area in slightly different ways, but I was just curious.
Yeah, I'll jump on that one. I think we live in a world of metrics, is quality metrics, value-based payments. And when I think about what we assess for metrics, is always very kind of drilled down to minute things about, did they get a PHQ or not? How late was their follow-up? Do we have changes in their PHQ? Are they on their medications, for 4 weeks at the onset and then into the maintenance phase? And it's all about those kind of small, minute medical things that we're being assessed for. And we spend just a crazy amount of time focusing on those things because we know that's what we're getting paid for. And there do exist, I have some examples of official metrics that have been approved by the federal government that are more about family-oriented care, but because they're not being mandated by the payers, they're not giving any attention to them. And I think the same thing is true with training people, that what we're assessing is where we're going to put our attention. And so if people know that I'm going to be assessed specifically on these family-oriented, family-centered activities, I'm going to read that article, I'm going to practice those skills, I'm going to make sure that I can demonstrate that for the person who's evaluating me. And so I think having robust, family-centered milestones is essential.
That's a good point. It seems like it has to be intentional right off the bat, especially in residency. So, Matt, any thoughts on that?
Yeah, I would agree with Randall. I think that we have a lot of good information about what kind of knowledge and skills medical providers and other people on the care team need to have. But I would say if you go to a training program, most of the family-centered care training is driven by an educator who's interested in that topic. I don't think we have enough incentive or guidance from the accreditation bodies or even from leaders at the specific universities or residency training programs. I don't think we have enough leadership and incentives and guidance for how we can disseminate family-centered care training across lots of different programs. I mean, there just aren't enough, Susan McDaniels or John Rowlands or Randall Wrights to go around across the country. I think we need to create standards and make it easy to disseminate it, no matter who is doing the teaching.
Yep. Well, I think it's a pay-it-forward field, so we're definitely looking for the future professionals to take the reins around that. And Matt, you mentioned incentives, and that was kind of my follow-up question. I know I prepped both of you before on talking about challenges of how the workforce develops moving forward, but why don't you think that family-centered practice or skills is incentivized that much? I mean, I think we all talk about it, and especially at different conferences, CFHA, STFM, others, on how important this is, but why don't you think it's incentivized enough in programs or in training? Are there barriers that come up that you think are more often than others that make it difficult?
So I assume that you're talking like from a financial standpoint.
Any standpoint.
Any standpoint. Well, I think it's hard work to do. It's hard to work with families. It can be intimidating. And I mean, some people embrace that kind of work because it's a little chaotic. There are a lot of moving parts when you're working with a family. There's so many things to assess and consider. And so it's not easy work to do. And that can be a barrier for some people. That's almost like a natural disincentive to work with families. But beyond that, I think we need a stronger base of research, or at least we need more highlighted research. I think there's already a lot of it out there. I think we need to do a better job of organizing it and promoting it and saying, hey, this kind of work is helpful. I mean, if we're going to move toward value-based payment models, we need to include family caregivers as part of the patient treatment, as part of the treatment plan. So I think there needs to be more done in terms of research so that we can go to whatever stakeholders or decision makers are in charge and say, hey, this is what the evidence shows. Let's start to make some changes.
That's a good point.
Yeah, I would just add to that I think the medical model is still the predominant healthcare model in the United States. And within that, most clinicians are specialists who are practicing organ-based healthcare. You have a cardiologist focusing on the heart, neurologist focusing on the brain, the nerves, your urologist focusing on the bladder and the urinary structures. And just that being, I'm guessing about 90% of the healthcare spend goes toward that type of care. And when that's such a huge player in the field, it's difficult to push things further and further up the biopsychosocial hierarchy to where it's the couple that's the focus or the family that's the focus. And so it's trying to figure out how do you engage an entire healthcare system to embrace the family as the focus of care, as opposed to tissues and molecules and organs.
Yeah, those are great points. And something in addition to that, I hear, I mean, operationally, you know, physicians talk about that. I'd love to do more of this, but time is such a barrier. If I spend 5-10 minutes more, you know, I'm delayed, you know, by X number of patients. But also we're hearing it in behavioral health too, that with briefer consultations that, as Matt, you said, working with the family is tougher, but that time element and is sometimes even the cost effectiveness part of it, even though long-term outcomes may be good, in the moment, people may feel challenged about that. I've been hearing a lot of that in the field. So sounds like there's a lot of a lot of ideas and things that we can grow on. It's just, I wonder if these barriers get in the way of it from ever practicing or piloting any of this or touching on that, but just some open thoughts to think about. But well, I want to make sure I have time for the last 10 minutes for audience feedback, and I know Naftali was going to control any participant chat there too, but wanted to open it up to the group who's on the call as far as any input, thoughts, or questions to circulate around.
Yeah, so folks can post their questions on the chat, or since it is a smaller group, folks can just unmute themselves, I think, and ask their question. And while folks are asking about that, if it's okay, I'd like to ask a couple of questions of Randall and Matt. Is that all right, Max?
Yeah, that's great.
So first of all, thank you for your really thoughtful and on-point presentations and discussion starters. I think there are more ways to stimulate our thinking on this issue. So, and I'm thinking about folks who are maybe not even present, but are maybe just listening to the recording, hosting this recording, and so especially folks newer to the field. So, try to, when you think about answering the question, I'm asking you to think about folks that you know, kind of don't have a lot of orientation to this issue. But I think it was Randall who mentioned making the family the unit of care. So thinking of primary care provider, maybe a resident, or a behavioral health provider. What do you mean by making the family the unit of care, particularly considering circumstances where it may be difficult or impossible to actually have the family all present at a medical visit?
Well, yeah, that is a great question. You know, I think there's some great writing on that from Susan McDaniel, Dave Seaburn, and forgetting on the co-author on that book. There's the book Family-Oriented Primary Care. I think that this is a great job of defining the unit of care and how that's applied. For me, what that means is that the clinician and the team always has a sense of what is the broader context for this family, for this patient. You know, who are their support people? Who should I be including? Who should I go out of my way to invite? Whose perspective should I elicit, either directly or through questions to the person themselves as to what would your family say? What would your mother say? What would your father say? It's creating spaces in the clinic that are family friendly, whether that's in the exam rooms or in the waiting room. It's always having a sense of, we as a clinic have family as the unit of care, and what are we doing now that limits that? What are we doing now that promotes that? And so for me, it's that kind of, again, that kind of codified statement of we are offering family-centered care, and then just kind of being relentless about how does that manifest itself? What do we do that promotes it? What are we doing that limits our ability to do that?
Great, thank you for that. That's really helpful. So the other question that I had, and this is sort of me putting probably my CFHA hat here, is, you know, it's sort of a challenging question to both of you. You've talked a lot about things that could be done, things that should be done, things that at exemplary sites you've seen done. When you think about, say, the next 5 years, what of the things that you have listed that should be done to promote this work, what would be the most actionable, do you think? What do you think you could see happening on a larger scale or becoming more of a standard in the next 5 years? And I know I'm putting you on the spot, so, but I'm just curious to see what you'd think.
Matt, go ahead.
Sure, I guess I have some thoughts. I don't know if these are realistic within the next 5 years, but I think organizations like ACGME should come out and say, this is how you work with families, and all the residency programs need to start to implement this training into their programs. I think that is very possible. They just have to look at the literature, what has been developed over the last 30, 40 years, and say, this is how you work with families. I think that CMS should also come out and, for those who are billing for Medicaid and Medicare, say, if you want to be able to bill, you need to have these certain workflows at your clinic. You need to be screening for caregiver stress. You need to be documenting the name of caregivers. And maybe not for every patient, maybe just for those patients with multiple chronic conditions or who are frail. I think CMS could do that, and that would make a huge difference. So I'm thinking this is very big level. Maybe down to specific disciplines. I think disciplines can come out and be very specific about what their competencies are. So PEDS can come out and have their competency list. Same thing for maybe internal medicine. I think that would not be very hard to do it as well within the next 5 years.
Yeah, when I think about what's happening here in Colorado, we are well on our way to completely dissolving the structure of fee-for-service and going full on into value-based payments and global payments. You know, I think our clinic is at least 60% global payments now and only 40% fee-for-service, and that number will drop about 10% a year until it's gone entirely. And I think that reality that we're living in now is our best chance of re-embracing a vision of family-oriented care. Just because what you're doing at that point is you're paying for quality outcomes rather than countable units. And you know, I believe that the best data shows that when you're engaging a family, when you're engaging a couple, when you're engaging a caregiver, that's when you are making, you know, second order change, higher level change in that family's life and getting the outcomes you're wanting. And so I think that challenge of saying we are now going to pay only for quality outcomes is what will drive us to embrace family-oriented care. And I think that's happening right now and will only get stronger as we move forward. This is an example, you know, with Medicare, you know, if they have a bounce back to the hospital where someone was inpatient, they went home and then came back within, I think it's within a month, you know, you don't get paid for the bounce back. Those types of incentives put the family at the heart of the intervention, where we're saying, we recognize that this person did well when they were in the hospital, but they went home to the home environment and all the gains they had made went away quickly. And so how do we intervene in that home environment to avoid the bounce back? That puts the whole financial onus right there on, we need to have people in the home doing care coordination, doing family interventions to ensure that doesn't happen.
Great, that's an awesome, really tangible example of what you're talking about. So Any other questions that folks may have? If you're able to unmute yourself, go ahead and do so. Otherwise, you can just use the chat function, and I'll relay the questions to our presenters. All right, I don't see anything off the top here. So, Max, I think we may be at our end. It looks like our folks are satisfied.
That sounds good. I know in the chat, I think Stephanie put a plugin for family nursing.
Yes, so there's a really helpful link if anybody wants to take a look at it. It's a position statement that the International Family Nursing Association put out. I think it's in reference to one of Matt's slides, where he noted that nursing is further ahead than other disciplines on this area.
Yeah. And again, just to put in a slight plug, transitioning into the next webinar in September, we're going to try to get Lorraine Bell, Janice Wright to possibly talk on family-centered care in the nursing field. So from a nursing perspective, I know Matt had touched on that, and we're hopeful for those presenters, but stay tuned for that.
Yeah, Janice Bell and Lorraine Wright.
Janice Bell, Lorraine Wright, yep.
Great. Well, thank you everyone for joining us today. And for those of you listening online, you've got a good taste of some of the work, the really important work that CFHA members do in this area and in really pushing to transform the field. So thanks, and we look forward to seeing you at our next webinar call.
Thank you, Naftali. Thank you, Max.
Thank you, everyone. Appreciate it.
Bye.